Hi everyone, my name is Dr. Sid Sudunagunta. I'm a board-certified veterinary cardiologist working in the UK. I'm pleased to be working with you tonight on Vet Candy's NAVLE Prep. Let me tell you a little bit about myself. I graduated from the Royal Veterinary College in 2011. I did complete the NAVLE along the way, though I never ended up working in the US. I completed my cardiology residency at the University of Liverpool in 2020 and passed my European board exams the following year. I'm currently working at a multidisciplinary hospital in the Midlands. I'm looking forward to discussing some cardiac topics with you, and I really hope these are helpful for you for your exam and also for your future career. If you have any questions for me, just post them in the chat and we'll answer them for you. Okay, let's get started. First up, let's talk about valvular heart disease. Myxomatous degenerative valve disease is the most prevalent cardiac disease in dogs, accounting for approximately 75% of cardiovascular issues in this species. Myxomatous degeneration is a condition characterized by the breakdown of the fibrous layer of the atrioventricular valves, leading to valve prolapse and the proliferation of the spongiform layer, which thickens the cardiac valve leaflets, particularly at their tips. This condition commonly affects the mitral and tricuspid valves in older dogs. While 60% of affected dogs have only the mitral valve affected, 30% have lesions in both the tricuspid and mitral valves, and less than 10% have only tricuspid valve disease. Typically, the mitral changes are more severe, and the clinical consequences tend to be predominantly left-sided, and the condition is typically referred to as mitral valve disease. While it is thought that all dogs will eventually develop some degree of valvular degeneration, middle-aged to older small breed dogs are most commonly seen with clinical disease. I'm sure you're all aware that Cavalier King Charles Spaniels are the poster breed for this condition. Dachshunds are also genetically predisposed, but really any small breed dog is a potential candidate. So Chihuahuas, Yorkshire Terriers, toy poodles, etc. The disease is slowly progressive. In the early stages, the mitral valve regurgitation is mild and a quiet murmur develops at the left apex. As the regurgitation worsens, the murmur becomes louder and the volume loading results in eccentric cardiomegaly. Ultimately, the volume loading may result in severely elevated left atrial pressures with subsequent congestive heart failure, which manifests as pulmonary edema, producing tachypnea and dyspnea. A cough is commonly reported, though it is important to be aware that these patients typically have concurrent respiratory disease, which is the cause of the cough. Cardiac disease may exacerbate this. Syncope may also occur. Sudden death is rare, but may occur secondary to left atrial rupture or rupture of a primary mitral valve cord. In terms of diagnostics, routine blood work like CBC and serum biochemistry profile and urinalysis are usually within normal limits in cases of valve degeneration, but they may help you identify systemic conditions that may also be occurring. In terms of cardiospecific blood work, measurement of the plasma concentration of N-terminal pro-B-type natriuretic peptide, or NT-proBNP, may be useful in dogs with mitral regurgitation. NT-proBNP is a cardiac biomarker which is released in response to cardiac stress and stretch. It is usually not increased in dogs with mild mitral regurgitation, but the levels increase as the heart enlarges and the patient progresses towards heart failure. The finding of a left apical systolic murmur in a middle-aged to older small breed dog is pretty typical of myxomatous mitral valve disease. The diagnosis is confirmed by echocardiography, which will show thick, nodular valve changes with prolapse and regurgitation. Depending on the severity and chronicity, there will be eccentric left-sided cardiomegaly, with the left atrium and ventricle becoming dilated and rounded. Cardiomegaly with left atrial enlargement is the characteristic finding on thoracic radiographs of an animal with degeneration of the mitral valve, and the size of the left atrium correlates directly with the severity of the regurgitation in small dogs. It's important to remember that radiographs will not show you the valve lesions or the regurgitation itself, but you will be able to identify cardiomegaly as a consequence of this process. An exception to this is when you have ruptured chordae tendineae and acute heart failure. In this situation, there isn't time for the left atrium to enlarge. The disease's progression can result in left-sided heart failure, causing pulmonary edema and breathing difficulties. In severe cases, right-sided heart failure can occur concurrently, leading to symptoms like ascites. The body compensates by retaining sodium and water, increasing blood volume, and enlarging ventricular chambers to maintain adequate blood flow. There is a well-established staging scheme for myxomatous mitral valve disease. Patients with mild valve regurgitation but no cardiomegaly are in stage B1, and no treatment is indicated, they can essentially be considered to be normal. When left atrial and ventricular dilation are present, patients are deemed to be in stage B2, at which point pimobendan is added. This has been shown to delay disease progression and the onset of congestive heart failure. If or when the patient does progress to congestive heart failure, they are in stage C, at which point diuretics are added. Either furosemide or more recently torazamide is available. Typically, an ACE inhibitor and spironolactone are added at this stage to counteract the renin-angiotensin-aldosterone system. Patients who are refractory to first-line diuretics are considered to be in stage D. At this point, other diuretics may be added, such as hydrochlorothiazide and amiloride. Other medications which have been shown to be helpful include amlodipine. Surgical intervention, such as mitral valve repair, is an option, but it is currently limited in availability, with only a few centers offering this throughout the world. Predicting which dogs will develop heart failure can be challenging, and long-term survival varies widely. Okay, let's talk about a case. A 9-year-old male Cavalier King Charles Spaniel presents with a history of rapid breathing and decreased exercise tolerance. On physical examination, a grade 5 out of 6 systolic murmur is detected at the left apex. Thoracic radiographs reveal left atrial enlargement and a perihilar alveolar lung pattern, and echocardiography confirms mitral valve prolapse with moderate regurgitation. So, what is the most appropriate initial treatment approach for this patient? Is it A, surgical mitral valve repair? B, pimobendan and diuretics? C, amlodipine and beta blockers? D, immediate referral for heart transplant? Or E, only monitoring with no treatment at this stage? Let me know what you think in the chat. Did you get it? The correct answer was B, pimobendan and diuretics. Pimobendan is recommended to improve heart contractility and reduce the progression of mitral regurgitation. Diuretics are used to manage fluid buildup in congestive heart failure, which the patient is showing with signs of dyspnea and exercise intolerance. Option A, surgical mitral valve repair, was incorrect. While this is a definitive treatment, it is not widely available, and medical treatment should be initiated first. Option C, amlodipine and beta blockers, was incorrect. Amlodipine is used to reduce afterload, but it's not the first-line treatment for mitral regurgitation. Beta blockers are not typically used in this disease. D, immediate referral for heart transplant. This is incorrect. Heart transplant is not a standard treatment for myxomatous mitral valve disease and is not commonly performed in veterinary medicine. And E, only monitoring with no treatment at this stage, was incorrect. This patient is showing clinical signs of heart failure, warranting medical intervention to manage the symptoms and improve the quality of life. Okay, next we're going to talk about cardiomyopathies. Cardiomyopathy is a disease of the heart muscle. There are numerous different conditions in dogs and cats. Cardiomyopathies can either be primary conditions, which are idiopathic, i.e. without an underlying cause. There will be a heavy genetic and inherited component, or they can occur secondary to systemic diseases or other influences. You may hear vets describe a heart as having a certain phenotype, for example, dilated cardiomyopathy phenotype or hypertrophic phenotype. This is when the heart shows the signs of a certain cardiomyopathy, on echocardiography for example, but it's not currently established whether the disease is a primary cardiomyopathy. So let's talk about some common cardiomyopathies in dogs. First, dilated cardiomyopathy, or DCM. DCM is prevalent in dogs. It's the second most common acquired condition, and it's characterized by progressive loss of myocyte number and function and decreased cardiac contractility. DCM commonly affects large breed dogs. Dobermans are probably the first to come to mind, but Great Danes, Dalmatians, Irish Wolfhounds, Cocker Spaniels are seen pretty commonly. Really, any large breed can develop DCM. Secondary DCM, or a dilated phenotype, can also occur as a consequence of taurine deficiency, chronic tachy or bradycardia, and there's some evidence in the last decade or so that certain diets, grain-free and pulse-heavy, can cause DCM as well. Echocardiography is the best test to definitively diagnose DCM. The left atrium and ventricle in particular are dilated, and contractility is markedly decreased. Mitral insufficiency typically develops as a consequence of dilation of the valve annulus, but this isn't the same as primary valvular disease, and the regurgitation isn't as severe as in mitral valve disease. Consequently, the murmurs tend to be quieter. Arrhythmias are more common in DCM than in mitral valve disease, and some dogs will have changes on ECG that predate echocardiographic or structural changes. Ventricular premature complexes are fairly common, especially in Dobermans and Great Danes. They can progress to more serious arrhythmias, and some dogs are at risk of ventricular tachycardia or fibrillation, which can cause sudden death. Atrial fibrillation is also fairly common, especially in Irish Wolfhounds. Most dogs with preclinical DCM are treated with pimobendan to delay progression, improve systolic function, and delay the onset of congestive heart failure. Standard heart failure therapy is initiated once they develop congestive heart failure. Prognosis varies based on the response to treatment. However, in general, DCM has a worse prognosis than mitral valve disease. Next is arrhythmogenic right ventricular cardiomyopathy, or ARVC. This is most commonly seen in boxers. It's sometimes referred to as boxer cardiomyopathy, although English bulldogs can also be affected. ARVC is characterized by fibrofatty replacement of the tissue of the right ventricular myocardium. The left ventricle can also be affected. This results in ventricular arrhythmias, which can range from isolated VPCs to ventricular tachycardia. Dogs can also develop systolic dysfunction, not dissimilar to traditional DCM. If patients have severe ventricular arrhythmias, they are typically treated with sotalol or mexiletine. Finally, Duchenne cardiomyopathy in dogs. Duchenne cardiomyopathy is an X-linked neuromuscular disorder primarily affecting golden retrievers. It results in myocardial and neuromuscular disease with characteristic ECG abnormalities and focal hyperechoic lesions on echocardiography. Echocardiography may demonstrate focal hyperechoic lesions affecting primarily the left ventricular and papillary muscle myocardium. The disease usually develops by 6 to 7 months of age, with the lesions decreasing in size throughout the next 2 years. The lesions result from calcification and fibrosis. In animals that survive, myocardial failure may develop. Prognosis depends on the severity of myocardial failure and overall response to treatment. Next, we'll talk about feline cardiomyopathies. First up, we have hypertrophic cardiomyopathy, or HCM. HCM is the most common heart disease in cats, characterized by concentric left ventricular hypertrophy. Primary HCM is likely determined to some degree by genetics, and genes have been found in Maine Coons and ragdolls, though there is likely a polygenic inheritance, and we don't have anywhere close to the information they have in human HCM. It's highly prevalent in adult cats, with somewhere between 25 to 30% of cats over the age of 10 being affected. The condition has quite a wide clinical spectrum. Some cats will have mild changes and be stable for many years. Others can be more rapidly progressive. Many cats will have a gallop sound or heart murmur, though not all. The clinical consequences of severe HCM, or indeed any feline cardiomyopathy, tend to involve either congestive heart failure, aortic thromboembolism, or, sadly, both. Congestive heart failure manifests itself in some similar ways in cats as dogs, i.e. pulmonary edema in left heart disease, ascites in right. One important and key difference in the way that cats present is that they frequently develop pleural effusion with left heart disease. This is extremely important to remember, as severe pleural effusion needs to be drained by thoracocentesis. Diuretics alone will not be effective. Aortic thromboembolism is a devastating complication of feline heart disease. In cats with large, poorly functioning atria, the pooling and swirling blood forms thrombi which can embolize, usually to the distal aorta, occluding blood flow to the pelvic limbs with resulting paresis or paralysis. This is extremely painful and the prognosis is very poor. Unfortunately, sudden death is also possible. Echocardiography is required to make a definitive diagnosis of HCM, upon which left ventricular wall thickening, greater than 6 millimeters in diastole, is present. Papillary muscle hypertrophy is variably present. Radiographic evaluation may show pronounced left atrial enlargement and variable left ventricular enlargement, but the cardiac silhouette can appear relatively normal if the left atrium is not enlarged. Treatment involves managing congestive heart failure symptoms and reducing the risk of thromboembolism. The prognosis varies, with some cats having a good long-term outlook, while others have a poor prognosis, especially in congestive heart failure. Next is restrictive cardiomyopathy, or RCM. RCM is the second most common form of cardiomyopathy in cats, characterized by a stiff, fibrotic, and non-compliant left ventricle with severely impaired diastolic function. The result is an increase in left atrial size and left atrial pressure, leading to pulmonary edema and/or pleural effusion. Diagnosis is made by echocardiography. Clinical signs of and the treatment for heart failure are similar to those for hypertrophic cardiomyopathy. However, the prognosis seems to be worse, especially for cats in failure. The cause of restrictive cardiomyopathy is unknown. Dilated cardiomyopathy, or DCM, is not seen very commonly in cats. Up until the late 1990s, it was much more prevalent. However, it was discovered that cats needed taurine to be added to their diet, unlike dogs. And after this change was made, the incidence of feline DCM dropped dramatically. It is still seen uncommonly, and it's similar to canine DCM, with echocardiography showing left ventricular dilation in systole and diastole with reduced systolic function. Arrhythmogenic right ventricular cardiomyopathy is also reported in cats, though it's not very common. Finally, there are some cardiomyopathies which don't fit into a specific category. They were previously called unclassified, but the new term is non-specific cardiomyopathy. Okay, let's look at some cases together. Case 1. A 7-year-old domestic short-haired cat presents with dyspnea, lethargy, and anorexia. Physical examination reveals a prominent left-sided heart murmur and mild ascites. Radiographs show severe left atrial enlargement and pulmonary edema. Echocardiography reveals a non-compliant left ventricle with normal wall thickness and chamber diameter, but markedly dilated atria. Okay, what is the most likely diagnosis? Is it A, hypertrophic cardiomyopathy, B, dilated cardiomyopathy, C, restrictive cardiomyopathy, D, arrhythmogenic right ventricular cardiomyopathy, or E, secondary myocardial disease? What do you think the correct answer is, and why? Let me know in the chat. Did you get it? The correct answer was C, restrictive cardiomyopathy. The case describes a cat with clinical signs of heart failure, severe biatrial enlargement, and a non-compliant left ventricle. These findings are characteristic of restrictive cardiomyopathy in cats. Option A, hypertrophic cardiomyopathy, was incorrect. HCM typically presents with left ventricular hypertrophy. Although left atrial enlargement can occur in HCM, the described echocardiographic findings of a non-compliant left ventricle with normal wall thickness and biatrial enlargement aligns more with RCM. Option B, dilated cardiomyopathy, was incorrect. DCM is characterized by dilation of the left atrium and ventricle with decreased systolic function. Option D, arrhythmogenic right ventricular cardiomyopathy, was incorrect. This condition primarily affects the right ventricle, not the left ventricle and left atrium. And option E, secondary myocardial disease, was incorrect. The case does not suggest an underlying condition that would cause secondary myocardial disease. Okay, next question. A 5-year-old male Doberman Pinscher presents with exercise intolerance, coughing, and occasional fainting episodes. Physical examination reveals a systolic murmur at the left apex and an irregular heart rhythm. Echocardiography shows marked left ventricular dilation and decreased contractility. So, what is the most likely diagnosis? Is it A, hypertrophic cardiomyopathy, B, dilated cardiomyopathy, C, restrictive cardiomyopathy, D, arrhythmogenic right ventricular cardiomyopathy, or E, Duchenne cardiomyopathy? What are your thoughts on the correct answer and why? Let me know in the chat. How did you get on? The correct answer was B, dilated cardiomyopathy. The described symptoms and echocardiographic findings, marked left ventricular dilation and decreased contractility, are characteristic of DCM, especially in a Doberman Pinscher, a breed predisposed to this condition. Option A, hypertrophic cardiomyopathy, was incorrect. HCM involves left ventricular hypertrophy rather than dilation, and preserved or increased contractility rather than decreased. It's also very uncommon in dogs. C, restrictive cardiomyopathy, was also incorrect. RCM is characterized by a non-compliant ventricle with severe biatrial enlargement and preserved systolic function, unlike the decreased contractility seen here. Again, RCM is also not seen commonly in dogs. Option D, arrhythmogenic right ventricular cardiomyopathy, was incorrect. ARVC primarily affects the right ventricle, whereas this case shows predominantly left ventricular involvement. And E, Duchenne cardiomyopathy, was incorrect. Duchenne cardiomyopathy is a neuromuscular disorder seen primarily in golden retrievers and involves characteristic ECG abnormalities and hyperechoic myocardial lesions, not general left ventricular dilation. Are you ready for another case? Let's go. A 3-year-old male Maine Coon cat presents for a routine appointment. Physical examination reveals a soft systolic murmur. Echocardiography shows significant thickening of the left ventricular walls and papillary muscles. So, what is the most likely cause of the patient's presentation? Is it A, hypertrophic cardiomyopathy, B, dilated cardiomyopathy, C, restrictive cardiomyopathy, D, arrhythmogenic right ventricular cardiomyopathy, or E, secondary myocardial disease? What are your thoughts on the correct answer and why? Let me know in the chat. Did you get it? The correct answer was A, hypertrophic cardiomyopathy. The echocardiographic findings of significant left ventricular wall and papillary muscle thickening are characteristic of HCM in cats. Option B, dilated cardiomyopathy, was incorrect. DCM is characterized by ventricular dilation and decreased contractility, not hypertrophy. Option C, restrictive cardiomyopathy, was also incorrect. Left ventricular wall thickness is normal in RCM. Option D, arrhythmogenic right ventricular cardiomyopathy, was incorrect. ARVC involves primarily the right ventricle, whereas this case shows left ventricular hypertrophy. And option E, secondary myocardial disease, was also incorrect. There is no indication of an underlying condition causing secondary myocardial disease in this case. Okay, this will be the final case in cardiomyopathies. A 6-month-old male golden retriever presents with exercise intolerance, muscle weakness, and an irregular heartbeat. Echocardiography reveals focal hyperechoic lesions in the left ventricular and papillary muscle myocardium. So, what is the most likely diagnosis? A, hypertrophic cardiomyopathy. B, dilated cardiomyopathy. C, restrictive cardiomyopathy. D, arrhythmogenic right ventricular cardiomyopathy. Or E, Duchenne cardiomyopathy. What are your thoughts on the correct answer and why? Let me know in the chat. Did you get it? The correct answer was E, Duchenne cardiomyopathy. The clinical signs, exercise intolerance, muscle weakness, and echocardiographic findings, focal hyperechoic lesions in the left ventricle and papillary muscles, are characteristic of Duchenne cardiomyopathy in golden retrievers. Option A, hypertrophic cardiomyopathy, was incorrect. HCM involves left ventricular hypertrophy, not focal hyperechoic lesions and neuromuscular symptoms. Option B, dilated cardiomyopathy, was incorrect. DCM is characterized by ventricular dilation and decreased contractility, not focal hyperechoic lesions. Option C, restrictive cardiomyopathy, was incorrect. RCM involves a non-compliant ventricle with preserved systolic function, not the specific echocardiographic lesions seen here. And option D, arrhythmogenic right ventricular cardiomyopathy, was incorrect. ARVC involves primarily the right ventricle and does not present with the neuromuscular symptoms described in this case. That's all for tonight. I hope you enjoyed our conversation and found it helpful for your studies. Good luck on your test. See you next time.